So thank you very much. We move on to the next session, which is symposium number 13. Can I request chairpersons, Professor Dharmaraj, Professor of Medicine, and Dr. Ramanathan, consultant physician, onto the stage, please.
As we are running short of sessions and we have 3 speakers in this session, let me call Dr. Vignesh, endocrinologist from Trichy, to talk on pitfalls in hormone measurement. Over to you, sir.
Good afternoon, everyone. So let us move on to the most important session, that is pitfalls in the hormone measurement. People think it is a theoretical topic, but what I feel it is mostly a clinical topic. So most of the time we do use our clinical judgment and lab correlation for managing our patients. So when there is some errors in the lab, we need to be able to identify the errors and to change the clinical decision. So we all know the quality control labs use various quality parameters. There's internal QC or external QC, what we call as quality assurance schemes for routine testing to identify the errors. So any form of interference, either it can be external interference or internal interference in the lab assays that leads to incorrect values that can lead to incorrect decisions. So clinicians should be alert that all immunoassays, either it can be chemiluminescent immunoassay or it can be a radioimmunoassay, that can produce error in its reports. So we need to identify if it is not matching our clinical decisions. So lab errors can be classified as, it can be a pre-analytical error, that is before the test is done, or an analytical error, that is test in the assay, or post-analytical error, so it is in the manual entering of the reports. So coming to the pre-analytical error, so it is happens when this starts from the identifying the patient and collecting the sample. So wrong timing of the sample is very common in hormone samples. So most of the hormones undergo the circadian rhythm. So for example, cortisol, testosterone, these samples has to be collected early in the morning. Suppose if these samples are collected in the evening or in the afternoon, we may have a falsely low levels. So timing of the sample is very important in hormone assays, and timing of menstrual cycle. Most of the hormones, FSH, LH, 17-hydroxyprogesterone, all we do in the early follicular phase, first 5 days of menstrual period, because the reference ranges varies for both follicular and luteal phase. And incorrect specimen interchanging plasma and serum can cause error reports. Unstable specimen or proper stability of the specimen. Most of the peptide hormones, for example, PTH, ACTH, C-peptide, which we do in clinical practice, are stable in the cold temperature. So if they are taken in the room temperature, they are prone for lysis. So I can show you the examples. The next comes is the analytical error. This error can happen with incorrect calibration. So every machine has a calibration with standard and which is checked by the control. So when there is a error in the standard and when there is an incorrect calibration, that leads to incorrect report. And there can be error can occur from imprecision or background interference, what we call as impurities, or endogenous drugs. Suppose somebody has on drugs, that's what the earlier speaker described. Somebody taking estrogen, it will interfere with the estrogen assay. Somebody taking hydrocortisone or steroid, prednisolone, it will alter the values of cortisol. So we need to look at that. And high dose Cook effect. This happens with prolactin. I will describe with case examples. And post-analytical, so when the test is done, so the assay is performed in the machine. So what happens? The lab technician see the value in the report and enter into the software to produce the reports. So if they enter the wrong value or wrong unit, so this is what we call as post-analytical report. So nowadays these post-analytical reports are usually reduced by interfacing. So they directly connect the assay machine directly to the reporting software. So the manual entry is often avoided, so interfacing, because of the interfacing. So what are the outcomes? So abnormal reports or wrong reports, either it can be pre-analytical, analytical or post-analytical, all leads to either elevated value, low value, so which we, based on the, which we take clinical decision, so which will affect the health of the patient. So most importantly, in a pre-analytical error, so sample collection, this is very important in hormone patients. So when we do estimation of insulin, C-peptide, or ACTH, PTH, these are all peptide hormones. The peptide hormones, normally there is an enzyme called peptidases in our blood, plasma. So this peptidases is the lysis hormones, so the patient will get low levels. So for example, if you send a patient for a C-peptide, ACTH, PCH to a lab, so if they collect in the room temperature without maintaining the ambient temperature, we will get a low report, so instead of a normal value. I will show you with the example. So this is one of the young diabetics who was labeled as type 1 diabetes because she presented with the severe hyperglycemia or ketosis, not acidosis. So she was started on basal bolus insulin. So multiple subcutaneous insulin, 3 units of regular and bedtime lantus. So what happens, so for etiological evaluation, she undergo C-peptide, fasting and postprandial, which came as low. So she was labeled as type 1 diabetes. So she was advised lifelong insulin, that to basal bolus. So, but clinically, she was obese. She doesn't have, so though she had ketosis, there was no acidosis. And she had clinical markers of insulin-resistant acanthosis nigricans. So I suspected there should be some clinical discrepancy between the lab and the clinical features. So I repeated the C-peptide in the standard precaution, in the fasting, in the cold chain. We have to we should take in the pre-chilled syringe, the ambient temperature, and put it in the ice, and transport the sample in the ice. And if the laboratory, they are processing immediately, they can process, or if they are going to process once a week or twice a week like that, they have to store in minus 20 degree. Many of the small laboratories may not have minus 20 degree deep freezer. So if any one of the steps is missed, the C-peptide will become 0 or low. So, and the diagnosis will change. So I repeated, it came as high, and this patient is probably a type 2 diabetes mellitus with clinical markers of insulin resistance. I tapered and stopped the insulin. She is well controlled sugars only with vildagliptin metformin. So this is how it affects the patient care. And this is an article published about the stability of C-peptide and insulin in room temperature and in cold temperature. So we can see the red one is a serum oil and violet is a EDTA. There is a progressive fall in the peptide hormones level when it is left in the room temperature. And over a period of hours to weeks, so if it is not processed immediately, if it is not stored in, not taken or stored or transported in cold chain, there will be loss of peptides. So it can happen with ACTH, it can happen with PTH. So we'll get a wrong report. If we expect a high PTH or high ACTH, instead we'll get a low PTH and low ACTH if it is not taken or transported in the cold chain. So coming to the immunoassay. So most of the hormones nowadays we perform with immunoassays, what we call as E-CLIA or CLIA. So immunoassays basically uses a principle called antigen-antibody reaction. So normally they have a measuring cup where it is coated with the capture antibody, and what we measure is an antigen. Usually a peptide, prolactin, FSH, LH, or analytes or antigens. And we have a capture antibody, and we have a detection antibody, which is tagged with biotin. Biotin is nothing but vitamin B7. So vitamin B complex, most of the vitamin B complex preparation will have biotin. And this biotin, why it is used? Because it can bind to luminous complex, what we call as streptovidin horseradish peroxidase. So this will, on stimulation, this will reduce light. So the light energy is picked up by the luminal detector, and this is how we record the concentration of the analyte. So what are the interference? There are two types of assays. It can be a competitive assay, or it can be a sandwich immunoassay. Sandwich immunoassay is basically for large molecules like TSH, and competitive is for small molecules. So what happens? So whenever there is an impurities or there are external factors that can alter these antigen-antibody reactions, either if the excess of biotin by vitamin supplements or an antibodies that can happen because of viral infection or asymptomatic, even general population can have an heterophil antibody or anti-streptovidin antibodies. See, any antibodies present in excess can to some extent affect the values of the patient. So I just put one problem. biotin problem is very common. So anybody who is on biotin and high doses can develop altered reports. So normally interaction with the streptovidin and biotin is utilized for immunosis. So these immunosis are susceptible for biotin interference. There are some immunosis where their biotin is not used. So whenever we have a doubt, we need to repeat the sample with the non-biotin immunosis. So the patient on biotin can have even elevated or wrong values. So biotin can interfere with the sandwich immunosis or competitive immunosis, alter either increase the value or decrease the values. So it can alter any platform, Roche or Siemens or Beckman. So these three are the most commonly used immunoanalysis in our clinical setup. So biotin can alter the T4 and TSH values. So what to do? So when you suspect a biotin, so generally we keep on increasing when the patient is on biotin, the lab gives TSH high. Whenever you keep on increasing the thyroxine to 200, 250, at last 300, and TSH is still not suppressed. We inquire compliance is good, and we have crossed weight-based dose. There is no clinical evidence of malabsorption, and patient is not missing any dose. So why even we are keep on titrating the thyroxine, and TSH is not coming down. So always suspect then biotin. So in which case, hold the vitamin tablets or a biotin-containing tablet for 3 days and repeat it, or you can put it in dilution. So if you dilute the sample by 1:10, the biotin levels will come down, and we can multiply the analyte levels into 10. Or you can use a different assay which does not use biotin. Or there are some manufacturers, they do have the biotin depletion protocols. So only thing we need to aware of such biotin can interfere with immunosis. So these are the case reports that have been published, how the biotin leads to wrong diagnosis. So there are case reports where a normal patient been diagnosed as Graves' disease because of high T4 and low TSH, or diagnosed as hypoparathyroidism, Graves' disease. And there are some biotin assay where they found high testosterone and high beta-HCG that leads to a wrong diagnosis of testosterone secreting tumor. All these leads to clinical implications, clinical decision making. So when you suspect there is a discrepancy about lab parameter and the clinical parameter, always repeat in a different platform or go for a dilution and after withdrawing the biotin. So it can alter any parameter. So these are the list of parameters, all the hormones. The most important thing is if it is an elective OPD patient, we can always call them after a couple of weeks and repeat it. But it is an emergency, like it can alter the troponin T, it can alter the BNP. So where we need to make a clinical decision making. So whenever your lab parameter is not matching the clinical parameters, always try to think about biotin and try to repeat in a different platform. So this is a case where the biotin, where I have seen recently, this is a 32-year male with history of infertility and decreased libido and erectile dysfunction. And he does not have any chronic medical illness. So examination is tall and testis was small, is 8 ml. Normal testis is 10 to 25 ml. And pubic hair was P3, that is Tanner stage 3, and axillary was present, and there was no gynecomastia. He was referred for evaluation of infertility and erectile dysfunction. So hormone test was done. So FSH-LH was high, and testosterone is very high, and prolactin was normal. Some analysis already done, it was showing azoospermia. So clinical impression was high testosterone, high gonadotrophin. So AIS, androgen, partial androgen or mild androgen sensitivity was made. But the patient was already prescribed all antioxidants for azoospermia by an infertility center. So I had but when I see the clinical, when the testosterone was high, and I see the clinical scenario, it doesn't look like androgen sensitivity, because androgen sensitivity usually have normal testicular volume, and generally they don't have axillary and pubic hair, and usually they present with gynecomastia. The clinical scenario is not matching with the lab report. So I stopped the biotin supplement for a few months, and we repeat the testosterone, it comes 200. So initially it was 1200, it was reduced to 200 after stopping the vitamin supplements. Now the diagnosis is low testosterone, high gonadotrophin, this is hypergonadotrophic hypogonadism. The diagnosis is Klinefelter syndrome. So treatment is entirely different for Klinefelter syndrome and androgen sensitivity. So we have to suspect the assay. When your clinical features are not matching with the lab assay, always feel free to discuss with the biochemist. If possible, we can repeat it in a different platform. So next comes the most important thing for during estimation, that is heterophile antibodies. These are the antibodies can present up to 40% of general population. It can occur after a viral illness or an infectious mononucleosis, that is Epstein-Barr virus infection. But generally, these they don't interfere with immunoassays, except in rare situations like 3% of cases. So heterophile antibodies are suspected when there is a discrepancy between clinical and lab finding. It is mostly with thyroid assays. We keep on increasing thyroxine dose and TSH is not suppressing. Or we have started, the patient is appearing euthyroid and the TSH is extremely high or a T4 is extremely low. So when the patient is clinically normal or clinically euthyroid, but the lab shows different thing, always suspect these antibodies. So this can be a blocking antibody or it can be a stimulating antibody. So these are the case report published where they found there is an increased TSH on biopsy, but on assays, and the patient were titrated with the thyroxine. At last they become thyrotoxicosis, and they identified this problem with the lab, and they compared. And the most important thing, we need to do a sample in dilution, or we need to change the assay method. Instead of usually they use anti-mouse antibody, we can change it to a different platform where they use anti-rabbit antibody. So we should change the assay platform and then decide on things. Next thing is, most commonly we come across changes in prolactin. In prolactin, the assay principle is sandwich immunoassay, where the two antibodies are used, capture antibody and the detection antibody. So whenever there is an excess prolactin, so normal prolactin is 25. So if it is like 100 or 200, it will be detected. If it is like 2,000 or 10,000, 20,000, it will not be detected in the same rate. So when there is an excess prolactin, so there will be changes in the detection. So the excess prolactin will bind to the detectant antibody, so it will be show as low value. So I can show you with an example. So for example, if there is an excess, very high excess in hormones, if it is like mild elevation or moderate elevation, it will be picked up by the assay. If there is a very high, extremely high elevation, normally the dose concentration is proportional to signal. So over a period of over a concentration, when there is a progressive increase in concentration, the signal reduces, what we call as high dose hook effect. So this happens when there is excess concentration of analyte. Though this can happen with any hormones, but most commonly in clinical scenario with prolactin. So this was a patient who is a 25-year woman who was evaluated for headache and amenorrhea for 6 months. She was not on medication. Because of headache, she was evaluated by neurologists. They found a pituitary macroadenoma, and the prolactin was slightly high. Normal is 25, and the patient had a 38. So she was diagnosed with non-functioning pituitary adenoma. So she came for evaluation. So I did, since it is a macroadenoma, I suspect a prolactinoma because she has an amenorrhea. So we did a dilution. It came into tumoral range. It comes around 6,000. So the diagnosis is prolactinoma, and she was started on medical management instead of surgical management. So non-functioning pituitary adenoma, we should go for surgical management. Functioning pituitary adenoma, prolactinoma is medical management. So entirely treatment is changed. So this is a case report recently published. So where they found a prolactin level of 31 in a pituitary adenoma, and they put it in dilution 1:10, 1:100, 1:1000. At last they found the value of prolactin is 2,80,000. So this is because of high dose hook effect. Very high excessive analytes, they block the antigen antibody reaction, and they show a falsely low value. So next clinical scenario is macroprolactin. So macroprolactin is nothing but very big prolactins. Normally we measure monomeric prolactin. There are certain clinical scenarios, that is in 10% of individuals, where we found macroprolactin. Usually it is attached to antibody, so it has a long half-life, but they are biologically inactive. They can be picked up by the lab assay, but they don't have any effects on any hormonal effects. So very high prolactin, patient is asymptomatic, so no galactorrhea, no amenorrhea, or no erectile dysfunction in males. So very high prolactin, always think about macroprolactin. It can happen in 10% of individuals. So MRI is not required in this patient. Always go for a polyethylene glycol, PEG precipitation. This is a screening test. If we precipitate the macroprolactin, we can identify only the monomeric prolactin, so original value of protein. So this patient requires only reassurance, no need for a cabergoline, or no need for a MRI, no need for a surgery. So this is how the lab. So this is how the prolactin, polymeric prolactins look like. It's a big prolactin, big prolactin, and monomeric prolactin. Monomeric prolactin is the one which has a biological effects in our body. The big prolactin, though it will be detected by the assay, it will not have any effects. If the patient is asymptomatic, very high prolactin, don't treat, just there are certain labs, they do PEG precipitation, you can request for them, and if you found it is a big prolactin, so no need for treatment, just reassure the patient. Just coming to the analytical interference, due to cross-reactivity, so many of the steroids, which we use clinically, hydrocortisone or prednisolone will interfere with cortisol assay. So anybody taking steroids, if you do a cortisol, it will come as high, except for dexamethasone. Dexamethasone will not be measured by the cortisol assay. So this is what known. So what is the clinical implication? If you have a patient with suspected adrenal crisis, the textbook says take a serum cortisol and then take an emergency serum cortisol and then give hydrocortisone. Suppose if you are not in a position to take a sample for cortisol, give a dexamethasone. This is a clinical implication. If you give a hydrocortisone and then you repeat if your patient get a hydrocortisone and if you do a cortisol, it will come as very high. So because it will be detected by the assay. So that's why it is very important to know how the analytes interfere with the assays. So it is important to, just in this last slide, sir. So important to identify and eliminate the error. So all clinicians may alert about the mismatch of the clinical and biochemical data. So we should not be carried out by a numerical value of the lab. So it can be an error. Labs, even quality control labs can give an error in its values. Always talk to your biochemist if you have a doubt, or if you have a doubt, you repeat it with the standard precautions. And to summarize, immunoassays are prone to interference, means errors. So correct reporting is responsibility of error. Many of the labs, they do specifically in dilution. When they get a high value, they do repeat checking or dilution values by themselves. So if they have not done, we should ask for a thing. Single testing may not be sufficient if you find an interference. Unfortunately, half of these patients with these erroneous reports go for clinical decision making and they go for further management. So the clinicians should talk to the biochemist and the lab technicians to know how the assay is processed, whether there is any problem with the assay before conclude a conclusion, go for a conclusion. Thank you.
What is the role of a lactograph axis test?
Pardon?
Yes, a lactograph axis test is a lactograph axis test in assay. Anything?
Lack of?
Lactograph axis assay. Any test is available for assessment of the prolactin?
Prolactin, usually it will be measured by sandwich immunoassay. So if we have a prolactin, it is easy, sir. If it is a macroprolactin, it is PEG. If you get for example, if it is because of a high dose hook effect, you can put in dilution. Just put in 1 in 10 dilution and 1 in 20 dilution. Most of the labs, they do either manual dilution or automated dilution. Machines, nowadays, the automated machines comes with the fully automated dilution. Just they have to press the numbers, how much dilution they require. So machines have fully automated dilution system, or you can tell our lab technician do 1:10 dilution. So that is possible.
Thank you, sir. I thought the topic was a little bit more theoretical, but you made it a very practical lecture. And so one of the take-home message of what I took from it is that when we are prescribing your hypothyroid patients, don't prescribe any B complex. Suppose they are taking B complex, ask them to wait for 3 or 4 days, then you do the routine assay of T3, T4 and TSH. That was a take-home message I took from myself, sir. Thank you for a great lecture, sir. So next topic to be discussed on this stage would be adult growth hormone deficiency. To deliver this lecture, I invite Dr. Usha Ayyagari, a consultant endocrinologist from Apollo Hospital, Chennai. Over to you, madam.
Thank you very much. Now, in the interest of time, I'm just going to launch into my topic without any delay. I want to start off by saying, actually, most of us will never start a growth hormone injection in our life. And I think it's more important to understand that there are certain preconditions to treating with growth hormone than, sorry, can I have my slides, please? Okay, when you project, that there are certain preconditions to treating with growth hormone, and it's as important to know when not to treat as it is to know when to treat. Now, the second thing I'm going to say is, unless you're a pediatric endocrinologist, even as an adult endocrinologist, you'll probably never start a growth hormone injection in your life. So on that caveat, growth hormone, it's a single chain polypeptide. It stimulates growth, cell reproduction, and cell regeneration. You might ask, what is the role in an adult? And we'll come to that. It affects everything from your nervous system to your cardiovascular system to your immune system to your muscular system and skeletal health. It's secreted by the somatotroph cells in the anterior pituitary under the influence of growth hormone regulating hormone, and its secretion is inhibited by somatostatin. But there are a lot of other factors including ghrelin, your gonadal hormones, leptin, and your thyroid hormones that can influence growth hormone secretion. Once secreted, growth hormone acts on the liver to produce IGF-1. Now, a little bit of basic science is important because when I talk about measurement and assays, we need to talk about IGF-1. So it produces IGF-1 primarily from the liver, but also from the brain, adipose tissue, kidney, and perhaps the skeletal tissue and muscle. IGF-1 acts on the tissues as a messenger for growth hormone activity, but growth hormone also acts locally in an autocrine and paracrine fashion in the adipose tissue and in the skeletal system and muscles. So with this brief introduction, we then come to the adult scenario. I'm not addressing growth hormone therapy in children because this is purely about growth hormone therapy in adults, growth hormone deficiency in adults. So in the adults, growth hormone is not an isolated hormone that we treat as one. If you look at growth hormone, it has quite a complex interaction with all your other pituitary axes. So growth hormone promotes the deiodination of FT4 to FT3, and therefore in growth hormone deficiency you will have less peripheral deiodination of T4 to T3, which is the active hormone. Growth hormone also has an incredibly intricate interrelationship with your HPA axis, and a relative cortisol deficiency can be present in growth hormone deficiency, and if you have cortisol deficiency, replacing with growth hormone may unmask it in quite a severe fashion and precipitate a crisis. Women generally need higher doses of growth hormone because estrogen decreases the levels of IGF-1, and men generally need less because androgen increases the levels of IGF-1. So it's quite complex and interrelated. If you look at growth hormone deficiency in the adults, one, you could have childhood onset growth hormone deficiency which is going on into adulthood. You could have idiopathic new onset growth hormone deficiency in the adult. But actually most growth hormone deficiency happens because of structural abnormalities in the pituitary or cellar or hypothalamic region, or due to traumatic brain injury or post-intervention like surgery or radiotherapy. So coming to this complex interaction of the growth hormone axis with all your other axes, systemically it has quite a lot of effects. So it can affect your psychosocial well-being and neurocognitive function. It can affect your cardiovascular well-being by affecting your dyslipidemia, endothelial dysfunction, your cardiac output. It has an effect on your metabolic health with insulin resistance and abdominal fat mass. It has an effect on your skeletal health with reduced muscle mass and bone mineral density. Now treating with growth hormone, yes, it does improve all these parameters, but the reason we don't universally treat with growth hormone is because changing these parameters hasn't really shown an equivalent improvement in your cardiovascular outcomes or mortality. So how do we look at the growth hormone in the setting of pituitary dysfunction? If you have a mass effect from a pituitary tumor, almost always the first to go is the growth hormone, and then your gonadal axis, and then your TSH and ACTH, which if you think evolutionarily is a wonderful mechanism to preserve your most important hormones till the last. And this is why isolated growth hormone deficiency is very rare, and you generally tend to see growth hormone deficiency in association with 1, 2, 3 or multiple pituitary hormone deficiencies. And this is why when you're looking at testing growth hormone, you always look at other hormones with it, because isolated in adults is extremely rare. Now, lots of guidelines, but this is the most recent and most up-to-date, the ACE guideline from 2019. And effectively, you look at growth hormone. Who do you test for? In people with hypothalamic or pituitary pathology, as we've said, structural or post-intervention, post-irradiation or traumatic brain injury, or in those who have verified childhood onset growth hormone deficiency. Because remember, in a certain small number of cases, even if it's diagnosed during childhood, they seem to grow out of it, especially if it's been diagnosed as idiopathic, and you must always reassess at the end of full skeletal growth. Now, how do you assess? I will talk to you in a minute, but in general, if you have multiple pituitary hormone deficiencies and a low IGF-1, that is enough to diagnose growth hormone deficiency in an adult. In those who don't have multiple pituitary hormone deficiencies and a low IGF, you can then test further. But the most important takeaway from this slide is, who do you not test? If you have multiple pituitary hormone deficiencies, please don't go on to test any further. IGF-1 is good enough. If you have congenital causes, so not idiopathic childhood onset growth hormone deficiencies, but congenital causes that include genetic mutations and midline defects, there's absolutely no need to confirm growth hormone deficiency in an adult. You treat as per usual protocols. But in all other cases, an insulin tolerance test is your gold standard. Here are the cutoffs. You can use an arginine growth hormone GHRH stimulated test, but usually what we go for is a glucagon stimulation test because it's well tolerated and its outcomes are dependent on BMI, but we do have BMI specific cutoffs. The masimorelin is quite expensive and not yet available in India. So if you look at the ITT, as long as you achieve adequate hypoglycemia, this is blood glucose levels, you actually should see a good increase in your growth hormone, and therefore the ITT is the gold standard. Now, why am I talking about doing growth hormone stimulation tests rather than just IGF-1? Because if you look at this data, this is IGF-1 in growth hormone deficient and the healthy population. Not much to choose between the two. Mean growth hormone levels over the course of 24 hours, also quite a huge overlap, as also your IGF binding proteins. But a growth hormone peak on an ITT clearly separates your healthy from your deficient individuals. And so the stimulated tests are the gold standard. Now, if you look at ease, convenience, safety, and cost, as I said, the ITT is the gold standard, but doing it is cumbersome and it is associated with certain risks to the patients, including the hypoglycemia. The glucagon stimulation test is reasonably accurate, correlates well with the gold standard. It's relatively safer than the ITT, and it's relatively more simple, and cost-wise is not much more costly, especially now that we have glucagon at 700-800 rupees in India. It's quite an affordable test. The masimorelin, as I said, not yet available in India and very expensive, although it is an oral agent that you can use to stimulate growth hormone and correlates well with the ITT. So then what do the guidelines say about having tested, whom do you replace? In terms of guidelines, NICE are the most definitive in terms of telling you whom to treat and whom not to treat, and it's simple. If you use growth hormone in adults with growth hormone deficiency only if they fulfill all three criteria. They have severe growth hormone deficiency on a stimulatory test. They have perceived impairment on the AGDA, which is your quality of life questionnaire for adult growth hormone deficiency, and they're already receiving treatment for other pituitary hormone deficiencies. So you need growth hormone deficiency, multiple pituitary hormone replacement, and your AGDA score. Now, having started it, you reassess 3 months of dose titration, 6 months of dose stabilization, and unless their quality of life on the AGDA score improves by at least 7 points, certainly in the UK, the recommendation is not to continue replacement. Now, for people who've been started in childhood, somebody else is controlling my slides from somewhere else. Go back, please, right. For patients who develop growth hormone deficiency in early adulthood, the criteria are no different. You treat it as if it was childhood onset, but you repeat at 25 years, and you do not continue unless they fulfill all three criteria. So if you start in childhood or in early adulthood, you do need to repeat and reassess at the age of 25 once they reach peak bone mass. After adult bone mass has been achieved, the growth hormone replacement therapy is based on the same criteria. Now, ACE basically just says test for severe deficiency and replace as appropriate. They're not as rigid as NICE in terms of cutoffs, 6 months, 9 months, reassess, stop. But they do say that if it's, once you've started, you do need to reassess periodically and look for benefit. Now, approximate doses as you get older, natural growth hormone levels decline and your replacement requirement is less. And in transition patients, so when you're going from adolescence to adulthood, if they have stopped, you can start at 50% of baseline and then go on. Remember, people with diabetes or obesity, people who are older in age, do require lower doses of growth hormone therapy. Once you start, you dose titrate at 1 to 2 month intervals, and then you reassess based on IGF-1 levels. Now, IGF-1 is useful for monitoring replacement therapy, not useful for diagnosis because of the huge overlap between healthy and deficient individuals. Now, what they say is you should, once you've stabilized them, the first 3 to 6 month period, you reassess approximately every 6 to 12 months. This reassessment should include clinical criteria, your weight related indices, and your waist hip circumference as a marker of visceral adiposity, your serum IGF-1 levels. Yes, bone density markers do improve with the growth hormone replacement, but you cannot use growth hormone replacement alone for bone density markers. And along with your growth hormone, you periodically reassess your other pituitary axis to see where they're at. Because remember, if you have started someone as an adult or as a transition for isolated growth hormone deficiency, there is a chance that they may go on to develop other pituitary hormone deficiencies, and therefore you need to reassess. The appropriate length of therapy is unclear. In theory, the benefits can continue indefinitely, but if there is no apparent benefit, and these guys are a little bit more relaxed, 12 to 18 months you could consider discontinuing. Now, they do say though that in those whom you discontinue, go back and reassess at 6 months, because the improvement in symptoms might be so gradual that patients might only be able to tell you in retrospect that they benefited from growth hormone therapy. So go back and reassess. But again, remember, they still have to tick all the boxes for replacement therapy for you to restart that growth hormone therapy. So in terms of side effects, it's mainly related to fluid and water and sodium retention, a little bit of musculoskeletal muscle stiffness, myalgia, arthralgia kind of symptoms. There is an improvement in insulin sensitivity, but again, like with the bone markers, you cannot use insulin sensitivity as the sole index for starting growth hormone therapy. There is a worry about potential induction of cell growth and proliferation and starting growth hormone therapy, especially post-cancer therapy, whether it's CNS related or peripheral. And there is a theoretical concern regarding tumor recurrence or de novo neoplasia. Formulations wise, we have daily preparations, which are the most frequently used. Long-acting growth hormone analogs are coming onto the market, but they come with certain caveats and still ongoing reservations, including safety and reversibility and the long-term outcomes in terms of cardiovascular and cell proliferation. So, if you're looking at growth hormone replacement therapy, yes, deficiency impacts bone, muscle, general health, heart, adipose tissue, and potentially longevity. Replacement improves bone and muscle strength and quality of life. This, while it's impaired with deficiency, or the risk is increased with deficiency, and the risk decreases in terms of cardiovascular risk and fat mass, the reason we don't use cardiovascular risk as a marker for initiating growth hormone therapy is, with growth hormone substitution, we have not actually shown a decrease in cardiovascular outcomes or cardiovascular mortality or all-cause mortality with growth hormone replacement. So you cannot use just these risk indicators to start treatment because the outcomes do not correlate. So the strategy is literally assess for baseline hypopituitarism, check if the patient is eligible for growth hormone therapy, assess other pituitary hormone therapies, replace pituitary hormones before you check for growth hormone stimulation tests, because you will not get an accurate result unless they're cortisol and thyroxine replete. Then do your stimulation tests as per local protocols and guidelines. If necessary, and you're looking at neuroendocrine deficiencies, please do look at your imaging for your pituitary. Make sure that you do your quality of life assessments and see how they improve. And severe growth hormone deficiency will require stimulation testing in the absence of multiple pituitary hormone deficiencies. So on this slide, I'm going to stop. Summarizes the same thing. Adults with clinical suspicion, if they have multiple hormone deficiencies and a low IGF-1, go ahead and replace. If they have few hormones, you may want to test further, which may include a stimulatory test. On the other hand, if they have a history and you have a low index of suspicion, no, stop right there. And if they have a normal IGF-1. But if you have a high index of suspicion and a low IGF-1, you again need to stimulatory test. So either in multiple hormone deficiencies with a low IGF-1 or with low suspicion and a normal IGF-1, you don't really need to test any further. But all other pathways really come down to at least doing a glucagon stimulation test. And if you don't have multiple hormone deficiencies, you may want to do more than one stimulation test. I'm going to stop here and I'm happy to take questions. Thank you.
Thank you, madam. Thank
Not
you
yet, I'm afraid. I'm afraid you are all standing between me and lunch, but thank you for asking.
Thank you. And about this stunted growth children around,
I don't do children. I'm not taking any questions on pediatric growth hormone deficiency, adult growth hormone deficiency.
More than 14 years. It is not pediatric?
But we do have people who deal with pediatric growth hormone deficiency, so I'm sure one of my colleagues might be happy to answer that question.
More than 14 years, does it?
More than 18, our territory, adult growth hormone deficiency only.
That is according to Indian...
I have a couple of colleagues who can take your question.
Indian Voter or Marriage Act. But
I think we can take up that question, madam, instead of wasting our time.
Sorry. Stunted growth children more than 14 years, can we do for any good thing with growth hormones?
So I think I can answer that question, although I'm not a pediatric endocrinologist. In various syndromes, including Turner's and Noonan's and just growth hormone deficiency or people with children with short stature, growth hormone has been shown to improve the height to a limited extent. But again, once they reach adulthood, you reassess as usual once they finish their skeletal growth. So once skeletal growth is finished, we come back to what I just presented.
But before losing, before becoming alert, if we can give growth hormone, they will be increased in height.
No, it's not as simple as that. They will still need to be assessed for any growth hormone deficiency. They will still need to be referred to a specialist endocrinologist who deals with children with growth disorders or short stature. They will still need to be reassessed periodically for linear growth, and only then can it be continued.
Kyphosis, any kyphosis?
I can see nods from my colleagues there.
If they have any kyphosis?
Pardon?
Kyphosis.
Okay,
I don't think that's an indication at all for growth hormone replacement.
Asked during the lunch time, sir. Further clarification can be added to the lunch time. Thank you for your question.
Thank you very much. Thank you.
Let us move on to the next session.
Thank you.
Next, let's move on to the next topic, sir.
Dr. Nidin Kapoor, Associate Professor of Department of Endocrine in the Christian Medical College.
So this is over to the speaker actually. We extremely thank the audience who are waiting for the lunch, and it is a paradox. At the lunchtime, we are all hungry and we are going to listen to a lecture that is place of anti-obesity medications in the clinical practice.
So very good afternoon. I understand I'm exactly before lunch and I'm talking about obesity, but I promise to keep on time. In the next 15 minutes or so, I shall take you through this topic of the role of anti-obesity drugs in our current day clinical practice. I'll briefly cover this by highlighting 5 points in this lecture. First, I'll talk about the relevance or the importance, why we need these drugs in our day-to-day clinics, in our clinical practice. I'll mention about the different classes of drugs that are available, the drugs which are already there in the market, the drugs which are likely to be there within the next few months, and more importantly, what is the evidence to bank these drugs. When do we start? We have a lot of patients with obesity, but who do we start treatment? When do we think of initiating? The follow-up, the role of other medications, which is equally important. And just before I close, we'll just touch upon the very important emerging role of genetics and drugs that are specific to certain genetic disorders in obesity. So starting straight with the relevance of obesity, I'm sure all of us here know that there's a huge prevalence of obesity globally. It's a pandemic. When you look at data from India, and this is data we published last year from the National Family Health Survey, where we know that about 35 to 40% of the Indian adult population has obesity. When we look at the same figures 10 years ago, these were in early 20s, and today it's 35, 40%. When you talk of our state here in Tamil Nadu, we have about 50% of people who are either overweight or obese. So that's a big number. To complicate things further, what we also know is that the Indian phenotype of obesity is very different from the West. We tend to have metabolic problems at a much lower BMI, and we also have this concept of normal weight obesity, where we know that not only it's common, but these people who have this huge amount of fat, despite the normal BMI, have metabolic problems, which are at par with people who are obese by BMI criteria. So I know I've started on a very gloomy note, and all this sounds very distressing, but what is good, what is something good that has happened also across the last few years is our knowledge and understanding of obesity has improved several-fold. Today we consider obesity as a disease, and we no longer think of it as an equation of energy intake and energy expenditure. Rather, today obesity is considered as a disease with several neuronal pathways which are altered, pathways which alter the appetite, the importance of gut peptides, the importance of adipocytokines, the importance of metabolic, behavioral, and environmental cues. And all of this put together gives a lot of options for developing drug therapy in obesity. When we look at the current guidelines for obesity management, and this is from the Canadian Obesity Network, which was published about a year and a half ago, today we focused not on reducing weight alone. Today we talk about improving the quality of life of our patients. When we actually looked at data from our own center, looking at quality of life in women with obesity, we find that it is the experience with dieting, the experience with lack of food, which is a major component that adds on to poor quality of life. I'm not saying that diet and exercise is not important, but what often happens in clinical practice when we start treatment with patients with obesity, they would lose weight, but they would come back after a while. Doctor, we've lost 5, 10 kgs of weight with very strict diet and exercise, but we're not losing anymore. We're stuck. And that's when probably the role of medications comes into place. Whenever we look at data, this is long-term data, including from the Look Ahead trial, the maximum amount of weight loss that we can achieve with good diet and exercise is about huge, 15 kgs on an average. But what really happens is if we do not follow that up, the long-term maintenance of data of weight loss is just about 3 to 5 kgs. So that's the exact point when patients come back to you, when you've done a good trial of diet and exercise and lost weight, they would come back, and that's the point when we need to start on medical therapy, otherwise they will be back to square one. So this takes me to the second aspect of my talk, talking about what are the different targets of weight loss medicines that we have, and what is the evidence to support them. Just the way we talk of diabetes, today we also have the Omnius Octet for obesity. We have a couple of drugs which target at least 3 of these factors, whether it's the brain, the pancreas, and the gut. 5 of these drugs are approved by the US FDA. Let's look at very briefly these drugs, talking about phentermine. In India, what is available is just a 37.5 milligram preparation. The biggest problem with this drug for obesity is it increases blood pressure, increases the cardiovascular risk, and that's a problem which is there in most of our patients with obesity, except in very young people, where this drug can be used, otherwise very difficult. But when you look at literature, large studies tell us that the weight loss to the scale of 10 to 12 kgs can be seen with the use of phentermine. Talking about combination of phentermine, topiramate, this is not available in India, the combination, but these drugs are individually available. As I said, phentermine 37.5, but topiramate 25, 50, and 100 milligrams are available as separate drugs. These are used as anti-seizure drugs, and if used in a patient with obesity, may help to lose weight. The big problem, apart from the problems with phentermine, which I mentioned, peripheral neuropathy is a big problem with topiramate. Again, the evidence, when you look at clinical trials, the weight loss is to the scale of maximum 10 kgs. When we talk of orlistat, and there's another drug which is available in India, there's a pancreatic gastric lipase inhibitor, weight loss to the scale of 6 kgs. It's not so helpful, but it's only in settings where people consume fat, and you have patients from certain sects who have to, follow their customary family norms of eating a particular fat-rich meal on some days, and that's the culture that they have to follow. It's very difficult for them to have something cooked separately, and in those people, you do see weight loss to the scale of 6 to 8 kgs. Otherwise, it's a weak anti-obesity drug. Talking about the fourth drug, the naltrexone-bupropion combination, again, both of these drugs are not available, but individually, naltrexone in India is available as a dose of 50 milligrams, bupropion to the dose of 150 or 300. It is shown to have weight loss to the scale of 5 to 6 kgs. Currently, we have a study which is ongoing using bupropion with zonisamide, and that should be in the Indian market very soon. Again, weight loss to the scale of 5 to 6 kgs helps to cut down appetite, but since this combination is not yet available, again, difficult to use. GLP-1 analogs, liraglutide 3 milligrams, we know the weight loss is to the scale of 8 kgs. We don't have 3 mg again in India. So cutting a long story short, of the 5 drugs that I've shown you, practically not much is available in India. What we have is orlistat, what we have is GLP-1 analogs that do not in the dose which is available. Semaglutide is the latest in the addition. So what are the drugs that we have or are likely to have in the next few months? And probably there are 4 things that I could highlight. We know about the oral semaglutide that was launched recently in India. Unfortunately, the oral semaglutide, the doses which are marketed currently in India are 3, 7, and 14 mg. The scale of weight loss is only about 5 kgs. Currently, the Pioneer Plus trial, which is going on, we at Vellore are a part of it. There, the same oral semaglutide is being given as 25 and 50 milligrams. And believe me, all the patients who are in the trial, I have about 12 patients in the trial, have lost about 15 to 20 kgs. The A1Cs, which were 10, are all down to 7. There is no placebo in the trial, so I know that is working. But till the time that is marketed, what we have very shortly, the next 3 drugs, I'll have a slide on each. What we will have, hopefully, within the end of this year is injectable semaglutide 2.4 mg, weight loss to the scale of 15% over 68 weeks, very effective, already in the US markets. Tirzepatide, this paper was published earlier this month, again coming into the market hopefully soon. Weight loss to the scale of 21% in this trial over 72 weeks. Again, a very effective drug. And the third is a combination of cagrilintide and semaglutide, and we at Vellore just started the clinical trial with that. This weight loss is at par with bariatric surgery. So yes, we have different combinations which are coming in with semaglutide, with tirzepatide and injectable semaglutide, and hopefully at least what we see is this should be available in Indian markets before the end of this year, a very promising drug. So overall, there are several drugs in the pipeline, and I think what we used to talk about the gap between lifestyle and bariatric surgery, today drugs are going to be far beyond into the realm of bariatric surgery by having weight loss to the scale of 25 to 30%. And this takes me to the third aspect of my talk as to when do we initiate drugs or when do we initiate treatment. Again, looking back at the Canadian guidelines, today we do not depend on BMI alone. Many years ago, when we used to talk of only bariatric surgery or drugs, we used to say, okay, BMI of this to this, you think of starting drugs, but things are changing today. We stopped talking about BMI as an indication for starting drugs. Simple clinical staging systems are more in use. This is something simple called the Edmonton staging system, wherein I may have a patient who's got a BMI of 40, may just have pre-diabetes. I would put that patient right at stage 1, whereas I may have a patient who's just BMI of 35, severe debilitating osteoarthritis, maybe diabetes with retinopathy, would directly be in stage 3. And why is it important to use this against BMI? And when we look at this data from NAINS database follow-up of over 15 years, we find that BMI doesn't really help in predicting any kind of mortality, but it is the staging system which clearly tells which patient will follow well or not. Today we have staging systems which are available which tell us that it's probably stage 3 where we have to use medical therapy. In our clinical practice, this is data from our clinic in Vellore, we have about 38% of people who belong to stage 3, so there is definitely a huge market for using therapy, anti-obesity therapy in Indian patients. This takes me to the fourth aspect of my talk, talking about follow-up and the role of other medicines. I think today obesity is classified as a disease. And like in diabetes, it's not that we've just started treatment today and then we forget about it. We need to follow them up. Recommendations at least monthly for 3 months and thereafter every 3 months. But the important take home here is that if in 3 months your patient has not lost 5% of weight with the anti-obesity therapy that you're using, it's probably not working in that patient, you need to change the drug. It's also important to look at the other drugs which are being used, and that's also important because there are drugs which increase weight for comorbidities, like for diabetes. I would like to avoid sulfonylureas, maybe use other, at least weight-neutral drugs, if not weight-promoting drugs. And it's really, really important, especially from a psychiatric point of view. It is important to look at these drugs because people with obesity often do have a lot of psychological problems. Again, this is data from our clinic where we find about 30% of people who actually walk into the obesity clinic have an underlying psychiatric illness. So yes, it's important to follow up, and it's important to also look at the other medicines. And just before I close, probably we'll take you through this last aspect of what is the role of genetics. I think we all stay in an obesogenic environment. It is probably the genes which tip off where somebody becomes morbidly obese, whereas somebody remains thin despite eating less or more. We have several studies to tell us that, yes, genes play a very important role in obesity. When we looked at this interesting study of mothers and their daughters in the community, these are postmenopausal mothers and their daughters who are married and settled elsewhere in a different environment, there is a strong correlation of the amount of fat that they carry. But really, what really compounds these problems of genes, especially in our southern states of Tamil Nadu and Andhra Pradesh, is the consanguinity, which is still quite prevalent. When you look at Western literature in consanguineous populations, just 3 genes could contribute to about 30% of the causes of obesity in children. When we looked at our data from Vellore, about 16% of young onset morbidly obese people have a genetic cause of obesity. Today, this is easy to detect with the help of next generation sequencing system. We can do a genetic panel test for about 10 to 12,000. And when do we suspect somebody to have a genetic problem? Any of 2 of these criteria. If there is somebody who has young onset morbid obesity, somebody who has family history of consanguinity, family history of young onset obesity, history of hyperphagia, or if they have mild to moderate developmental delay. What we found in Vellore is the most common mutation is MC4R. And believe me, these patients who have this MC4R mutation are just young and morbidly obese. They really don't have any of these mental impairments and visual impairments and developmental delays. So sometimes they may be missed off as just constitutional obesity. But why is it important is today we have drugs which are helpful to target these specific mutations. When you look at literature from setmelanotide, about 30 to 40 kg weight loss can be achieved by just giving this drug which handles the specific mutation which may be defective. So yes, the role of genetic testing is also coming back. So with this, I would stop. The key takeaways from this lecture would be, yes, obesity is a big problem and anti-obesity medications are important after having given a good trial of lifestyle. The way we have an omnious octet for diabetes, similarly for obesity, 5 US FDA approved drugs, but the drug that really stands out with respect to the quantum of weight loss is GLP-1 analogs, several of them in the pipeline. It is important to think of starting these medications not just based on BMI, but looking at comorbidities and simple clinical staging systems. And yes, there is an upcoming role of genetics as well in managing obesity with drugs. So I'd like to stop here. I'd like to acknowledge the team of obesity management at CMC Vellore, and would be happy to take any questions.
Thank you, sir. Thank you for a very informative lecture, sir. Because we have finished 4 minutes earlier, we can take 2 or 3 questions from the floor, if at all anybody wants to interact with the speaker.